Good afternoon. Thank you for joining us for the AGA webinar, Have You Chosen an Electronic Health Record? What You Need to Know. I'm Ron Fogel, the Community Private Practice Counselor of the AGA Institute and a private practitioner in Chesterfield, Michigan, a suburb of Detroit. There's been much pressure on GI practices in recent years to purchase and implement electronic health records, or EHRs, for their offices and ambulatory surgery centers. However, researching, identifying, purchasing, and transitioning to an electronic health record from paper records can be confusing, expensive, and risky for practices both large and small. There are a number of current and pending government regulations that will first reward us and then penalize practices for their use or non-use of EHRs. In addition to the pressures from health insurance companies to show value of patient care, patients are now also expecting electronic health records. Now is the time to start incorporating EHRs into your practice. There are a number of practices from around the country that have successfully managed this transition and have started to receive the incentive payments from the federal government for successfully meeting the Stage 1 criteria for the meaningful use requirements. Today, we will hear from Dr. Michael Weinstein, a recognized expert in electronic health record implementation, who is a leader of a large independent GI group based in Washington, D.C. Dr. Weinstein will discuss the process that he and his colleagues used to complete their purchase of an EHR. After his presentation, we will answer questions. To ask a question at any time during the webinar, please type your question into the question panel on the right of your screen. Mike, can you please begin?
Thank you, Ron, and I want to thank the AGA and welcome everybody onto the call, and hope that I can be helpful in your search. I'll assume that everybody hopefully is still looking for an EMR and are not in the process of actually changing electronic medical record. So basically, we'll start with just sort of, I think everybody probably understands the pros and the cons of electronic records versus paper records. Electronic means secure, real-time, interoperable, point of care, patient-centered information. It allows us to connect to lab systems, pharmacies, image systems, all the other information sources that end up often in a paper record. Electronic systems allow you to actually do electronic ordering and then track the order for completion. It assists in the coordination of any billing task within your office, so that when the electronic note is completed, the claim is immediately created without any additional paperwork. And the better electronic records also even provide clinical decision support tools to help you in the immediately during the process of the provision of care. And obviously, there are cons to electronic records. They're extremely costly. Implementation is very complex, and it requires everybody to be on board. If you have one or two naysayers, then they will sink the ship. Next slide. You know, our objectives and goals can be looked at in a couple of different ways. Certainly, the goals that we've seen published by CMS, by the Office of Health Technology, their goals are maybe a little bit different than a physician's goals. You know, they look at electronic records as a way to improve quality, safety, efficiency, reduce the differences in how health is delivered to different populations. They want to engage patients and families in their health care, hoping that with a little bit more skin in the game that preventative health measures are more successful. Improve care coordination between providers. They want to improve the general public health by being able to look at the data. They want to ensure privacy and security protections, and they have established the meaningful use criteria. Obviously you can look those up on the CMS site. Next slide. As a physician, the goals are sometimes a little bit different. You know, we want to improve care, but we also look at electronic records as possibly and hopefully being able to reduce costs and improve efficiency within the office, lowering our overhead. Many of the electronic functions that are done by hand, by people, by paper, can be streamlined to decrease the time and decrease the error rate substantially within the office with electronic records. And of course, the physicians are interested in the $44,000 high-tech incentive payment, which, by the way, if you have not implemented electronic records yet, and it's now November, your maximum incentive is now down from $44,000 to $38,000, I believe. So you missed the deadline for 2012. Next slide. When we went through this process, and just a little background, my group is a merger of 7 different practices now under one umbrella, Capital Digestive Care, 55 physicians at 17 different sites, 17 different office sites. So a very complex organization to do an electronic record. And when we sort of set up our team to decide which electronic record we were going to use, we made our team very large, making sure that we had input from all aspects of the practice, a lot of different divisions, and a lot of different people who would be touching the electronic record, not just the docs, but medical assistants, administrative people, billing and coding people, and the prior paper medical record people. We managed this entire process looking, to look at what our requirements were going to be, then look at the vendor options, then selecting the product, negotiating the contract, and finally doing the implementation and training. The committee had the approval of our board and pretty much took our recommendations without much discussion. Next slide. We did set some pretty high-level goals. We did use the AGA's EMR field guide. I recommend it. It's not expensive, and the process is very much laid out in that little guide, the little blue book, as we called it. This helped us determine what our requirements were going to be and how our electronic record sort of touches everything else within our office. It is, as we said before, it's a very expensive project, and we wanted to make sure we maximized the return on the expense. The $44,000 per doc is nice, but I will tell you that if you look at the entire first 5-year cost of purchase, training, implementation, downtime, maintenance of everything over the 5 years far exceeds the high-tech stimulus money. Next slide. So our work plan, we developed a project plan and a timeline. Just to give everybody an idea, we took over a year to decide which electronic record we were going to purchase. As part of the process, we did a readiness assessment. I'll talk about that. And we looked very closely at the current workflow, which differed quite a bit at different offices. Next slide. A readiness assessment really meant talking to everybody in each of the offices as to how they were currently managing their medical records. If they were on paper, how did the information flow from their front desk to their chart, from the chart to the exam room, from other paper in their medical record office? How did the information flow in their present status, and how that might have to change with an electronic record? So everybody was sort of in on that stuff, and we really drew some workflow diagrams to try and figure that out at different locations. We looked at, again, we had the organizational issues, the operational issues. The data management issues is not just the notes that the doctor creates, but all the other pieces of data and forms that come into an office that end up in a medical record. We had to look at our risk analysis, meaning to some extent all the privacy issues, and then the technical issues is the hardware and infrastructure side of the issue. Next slide. Like I said, we mapped out the process. On the administrative workflow, that's sort of the scheduling, how incoming calls were handled and how the information from an incoming call might end up in a medical record. Our registration process, how our current, some of our divisions used paper super bills and paper claim preparation, and that obviously changed with an electronic system. The clinical workflow, again, how patients were roomed. Did doctors tend to see patients in their consult office? Did they see patients in their exam rooms? And try to look at their prior workflow and how that might have to change with an electronic system. Next slide. In determining our electronic medical system requirements, again, the AGA manual is very helpful. It sort of lists a lot of the aspects of an electronic record that you want to make sure that you have. Our initial vendor list was actually more than 30 different companies. We developed an RFP, a request for proposal. So we made our list of our requirements that we wanted to make sure that we would have in our electronic medical record. That included things as minor as being able to do voice to text, being able to do keystroke entry, being able to do on-site scanning, patient portal options. Again, I really recommend the GI EMR book to help you make that list of criteria. From our RFP, we sent out RFPs actually to 30 different companies, a form that said, this is what we would like. Would you like to offer us a proposal to provide your software to our group? We got back 12 out of the 30. So right from the get-go, 18 companies didn't even want to reply to our request. We developed, from the 12 that came back, we developed a short list of 8. Next slide. Now there's a picture of the field guide. Next slide. From each of the vendors, we got the names, the address, all the company information. How big were they? What was their market? What was their market exposure? How big of the market did they have? Tried to figure out if the vendor that we were going to end up with was going to be stable enough to survive what will obviously be a very tumultuous next 4 or 5 years as meaningful use criteria developed for already there for stage 1, but then stage 2, and finally stage 3. And we wanted to make sure that the company would survive all these changes. It's very expensive, and some of the vendors are somewhat thin in the cash department currently. Next slide. Again, our list of requirements. Probably the most important things, we wanted to make sure that they had the experience in gastroenterology. There are a lot of electronic medical record options out there that have very little exposure in the GI community. So we wanted to make sure that they were thick in GI, that they had GI templates and or support for gastroenterology template development. We all use ambulatory endoscopy centers, and it was very important that the office electronic record would be able to fully integrate with our endoscopic systems or have a fully integrated endoscopic system as part of the electronic record. We want to make sure that they were all C-CHIT certified or at least planning to be certified. We needed to make sure that they would provide us with a timeline and stick to the timeline. We want to make sure that they would have quality reporting and improvement tools, be able to participate in the registry, like the AGA registry specifically, or even GI Quick, be able to produce performance measures. We wanted to make sure that the electronic system would automatically integrate with these registries and not require a lot of manual entry to capture outcomes. We were hoping that the vendors would have the experience on the technical side, the infrastructure side, and if they didn't, we needed to know that going in so that we could arrange for technical support if needed. And we wanted a system that we could really look at our outcomes, be able to query the system without getting a lot of technical support. And we wanted to be able to do that on site. Next slide. Next slide. There we go. Some of the GI specific documentation. You know, we looked at our old practice management system and looked at the most common diagnoses that were used in our practice, came up with actually a relatively short list. So these 10 topics really encompass probably 80% of all of our office visits. And if we want to make sure that the electronic record had at least these 10 symptoms or conditions automatically templated at the get-go. Next slide. Once we sort of narrowed down our list, we had a drive-by. We basically did online demos with the 8 vendors that we got down to sort of get a little bit more information, realizing that online overview demonstrations are often smoke and mirrors. They can make a system work perfectly in a demonstration. We did have after the initial demos, we came down to our final 4, like March Madness. We had them come and do on-site demonstrations. We had all 4 vendors come on the same day. We had a location set where all 4 vendors could set up, and that we could rotate groups of staff and physicians through all 4 demonstrations. So each demonstration lasted about an hour, and everybody came for half a day to do on-site demonstrations. And we got everybody's input on what they were able to glean from a live demonstration. We then started visiting GI practices. I don't think there's anything better than seeing a software in use in a real situation and talking to people who are actually using the software, who are not employed by the vendor. We also did these visits not only to look at the software, but just to look at the technical setup, how their servers were set up, how the infrastructure was set up. And we specifically for our final 2 choices, we really needed a lot of infrastructure input. And then we did the contract negotiations with the 2 finalists. Yeah, we played them off a little bit against each other, even though we had a little bit of a leaning towards one. We wanted to make sure that whatever the price was going to be competitive with our alternative. Next slide. When it comes to doing the demonstrations and the site visits, we tried to do this objectively. You'll see on the next couple of slides we have a couple of forms that we use to gather the opinions of the people who were actually doing the visits for us. And we took on our visits not only physicians, but we took a technical person and we took a medical assistant from our office to our site visits, and tried to get everybody's opinion objectively to be able to measure the differences between the options. We wanted to, again, assess the system functionality, how easy was it to use, what their implementation experience was. Was it easy to learn? Was it not easy to learn? How did their workflows adjust from before to using the software, and whether or not they were having those technical problems, ongoing technical problems. If possible, I recommend going to the user group meetings, if those exist, for the software you might be looking at, and hopefully the timing of those user group conferences would fit with your schedule. Next slide. This form obviously you can't read, but I'd be happy to provide these assessment lists, criteria lists that we used with my email, which I'm sure you can get, and I can send these to you. Next slide. That was one of the lists. That was the criteria and the This is a little bit slightly more legible, but still not well. This is the site review form that we use to gather opinions from the people who are on the site visits. Next slide. In the contract negotiation, again, I'll tell you, when you do this, the implementation process is difficult, and the hardest thing is when physicians or staff try and make the electronic record fit your current workflow. Unfortunately, the way software is built, it's built with a workflow in mind. And I think one of the issues everybody will probably have is realizing that once you've selected the electronic record that you want, you have to adjust your workflow to match the workflow in the electronic record. Trying to do it the opposite way is going to be frustrating. It's easier for the staff and the people to change how they do things than it is for the electronic system to change how it does things. We made sure that we had an on-site dedicated vendor project manager. That person was with us for 6 months during the rollout and implementation phase. Our rollout was obviously longer than most groups because we had 55 physicians to train and over 100 medical staff people to train. So for us it was a long drawn out process. It probably could be done in less than 2 months in a smaller group setting. We wanted to make sure that the vendor would help us customize their templates. And if one of the vendors we did talk to did not have a lot of GI experience, but said that they would provide us with a programmer to help us build templates. We thought about that for a while, but their estimate as to how much time a programmer would need to build us templates seemed to be far short of what it would probably end up being, and which meant that after we had used up the hours in our contract, we would be on the hook for paying for programmer time to build templates. When you do obviously the installation, there's large differences between a setup like ours with central servers and infrastructure versus a single location that could make things a lot easier, particularly when it comes to user authorizations and permissions and security issues. Next slide. Again, in addition to setting up templates, we made sure that we would be able to have our customized reporting, so be able to do some outcomes measures ourselves. This certainly required also making sure that the interfaces with the registries and stuff would work, and making sure that interfaces with labs would work. The labs that we used locally would interface with this software. We wanted to make sure that our pharmacies were in the system. And let's see, let's go on from there. I'm just sort of running on. Next slide. Again, sort of towards the end, once you've sort of selected the software, you need to build your implementation roadmap, how everybody's going to be trained and what tasks that everybody's going to need to do, how the data is going to be captured that's required within the record. And it's important to look at your prior workflow that you did during your readiness assessment, and then track that over to the workflow that the vendor recommends for their medical record office note building in the office. You need to match each data element that you used to capture before and how you're going to capture it afterwards. The other issue that comes up is if you're on paper records, you need how are you going to get your old medical records into the new system? How are you going to do all that scanning, and what format you're going to use to divide up your old paper charts into the new electronic system. And assistance from the vendor and from other practices is very helpful for that. Next slide. Again, this is just the final slide on, I think, on infrastructure. And again, this very much depends on your site if you're multiple sites, you have a much more complex infrastructure setup than in a single site. So I think I'll hold off on this and answer questions on infrastructure depending upon the people who are listening. Next slide. Yep, questions. So I tried to run through that pretty fast. Certainly can stick around a little while if people have questions that are more specific to their needs. Like I said, it took us over a year to decide which electronic record that we were going to use, and then it took us 9 months to do the implementation and training and go live for all of our 55 docs. So very long process, but we did get it all in so that we could successfully attest for meaningful use. We're waiting for the check.
Thank you, Mike. That was very informative. We have time for questions. Just to remind you, if you have a question, type it into the question panel and it will be answered in turn. The questions will be read through the AGA office, and we'll also post a question and answer. We'll have it on the website for any questions that we don't answer now. So, Amy, are there any questions?
Yes, hi. The first question is, we are interested in reporting quality data into a registry. Do all EHRs have that capability?
Well, not all EHRs have automatic interfaces into the current registries, whether it's AGA registry or the GI Quick registry. So GI Quick is only for colonoscopy, colorectal cancer screening and colonoscopy information. The AGA registry includes other aspects, and if you're not only if you're trying to get outcomes, but you're trying to submit data for PQRS so that you can get your Medicare bonuses, or if you are working with an insurance company that wants data from AGA registry, has a contract right now with United Healthcare to help them gather data for bonuses within their provider contracts. Not all EHRs can be automatically linked, but all the registries have options that can take data files and use an intermediary. AGA uses FigMD to scrub the data and make it compatible with the registry. So there are a number of ways to get the data from an electronic medical record into a registry, and it really is specific to which EHR you choose. Some of them go direct. I mean, I think the only one that goes direct actually is GMed. The only one that goes direct into both GI Quick and AGA registry. That's the only one that does both.
Right. This is Ron Fogel. We have an electronic health record that we bought from a local vendor, and we had looked to interact with the GI registry. The problem is connectivity and connectivity charges. So it's very important as you look for connecting to registries to find out who's going to pay for that connectivity. Sometimes the portals can be very expensive in the range of thousands of dollars, and they're often monthly charges. We're looking at FigMD right now, and we may be using that as the way to connect to the registry to get our payments.
Thank you. The next question is, can you tell us which systems you selected?
Ron, you first.
Okay. We are a small two-man group, so our thought process was different from Mike's. We were looking at, and we also wanted to get the incentive payments for this year. We started looking in January. We met with a number of different vendors, and we ended up choosing a local vendor called GlowStream. And the reason why we chose them was because, A, they were local, and we knew that we could get people into the office if we were running into trouble. We knew that the trainer was local and that she could sort of stop off on her way home and help us. And we felt that this was important to us. For GlowStream, the training period was a couple of weeks, and they came in and they looked at our workflow and then designed the software to facilitate as much as possible our current workflow. Plus, they had a money-back guarantee. They said if we weren't back up and running at our current rate within 3 weeks, they would pay us a couple $1,000s. It's now 90 days later. We're not quite up to that old rate, but we're pretty close, so we didn't bother going after them for the money. But we went with Gulfstream, which is a local Michigan company.
Right. Well, I'll tell you, our final four were NextGen, Centricity, Allscripts, and GMed. We probably could have predicted that those four were going to be in our final group because there are very few vendors out there that have the experience with a group of our size, and we didn't want to be a beta for a vendor to figure out how to link up 17 different sites and train as many people as we had. So we needed that stability. Ultimately, we ended up choosing GMed. The main reasons were the full integration into our surgery centers, into our endoscopic centers. So GMed has a fully integrated EndoWriter, and that ended up being probably the key criteria, was that complete integration of the two sites, the office and the ambulatory endoscopy center. It's not that they're the only group that can integrate with an endoscopic record. Centricity and Allscripts integrate very well with GMed. If you have GMed in your endoscopy center, they integrate also with probation. NextGen, I think, also integrates with GMed. So there are other ways to link two different vendors together, but because we were sort of at the beginning, we figured that one less interface between two very important systems was a higher priority for us. So we ended up with GMed, and that's probably the main reason.
Thank you. The next question is, did you have any unanticipated expenses after purchasing and implementing your EHR? Were there any hidden costs that surprised you?
We didn't have any hidden costs with our GMed system. I think that they're pretty much right on, and they had enough experience with large groups, and because we were pretty careful in negotiating to make sure that we had enough training hours, and they helped us with the interface stuff. I think some of the expenses that maybe we underestimated, although GMed did try and warn us a little bit. Scanning your old paper charts is a very expensive, tedious process. It requires either a lot of people or a lot of time to move all those old paper records into electronic format. Our infrastructure, our connectivity, setting up a high-speed fiber MPLS network to 17 different sites. I think we underestimated the amount of time that would take with vendors like Verizon and Windstream, particularly because putting a physical fiber line into some of our sites was more complicated than we thought it would be. So that's the hidden costs were not so much on the software side, they were on the infrastructure side and the conversion side.
Thank you. The next question is, do you know whether GMed integrates with probation?
I don't know if they do. GMed in the office, probation in the endo center. I imagine they might, although I could see why they might not, because obviously they're competitors in the endoscopic center. I would imagine that if you had probation in your endoscopy center, it would be an interesting question. I don't think that didn't come up for us, and it never really was a question for us. But both systems are relatively open. Probation obviously interfaces with a lot of practice management systems, interfaces with other office endoscopy system, office EHR systems, and And GMed, like I said, it would be a good question. I think I could probably find out the answer, but you could probably find out the answer as well.
Thank you. As a quick reminder, if you have a question, please type it into the question pane. The next question is, did you continue your full patient services while transitioning to your EHRs?
Ron sort of hinted, good question. No, we under guidance from GMed and a bunch of other practices that we talked to about implementation, we cut down to a half schedule for 3 weeks at every site. There were some recommendations from some of the other groups that we talked to suggested we should do it for longer than 3 weeks. But we felt 3 weeks was a pretty expensive cut down. That's basically cutting your revenue by a week and a half for the period of time. That's a lot of cash flow. So we did not cut down our schedules in our endoscopy centers. So we ran those at full schedules, and that's because our endoscopy suites have already pretty much been on various electronic systems for a long time. So the staffs there were a little bit easier to train, but we did cut down the offices to half schedules for 3 weeks.
It's not only during the learning phase of electronic health records. Depending on how you set up your records, it could be that you're not going to be able to run at the same rate for forever. If you use a voice recognition system to enter your notes, it takes longer to do than scribbling notes on a piece of paper. If you do your own typing, unless you're a very efficient and quick typist, you're not going to be as fast as writing notes on a piece of paper. And even with templates, you think just clicking goes fast, but it actually takes time to click and get everything in that you need for your note. So I think, at least we found that we're not as efficient as we were when we used to write on paper.
And I'll make one other comment. It's, if you were efficient before because your records were thin and your documentation was sometimes maybe incomplete or illegible, it's going to take you longer to use a system that makes you comply with the current documentation requirements to have past medical history, medication reconciliation, all the things that really sort of create some quality and decrease errors. So yeah, you definitely won't be able to go as fast as you used to go if your previous speed was related to being incomplete. The EHR makes you be complete, so even when you're going as fast, quote, as fast, it will take you longer because you were actually skipping steps before. I've had that discussion with a few of my partners who complain about they can't go as fast before. But if you audit their records from before, there would be some pretty weak audits. So can't blame the software for the changes in the requirements for complete documentation.
I agree with that, and I think that the quality of your records is improved by having the electronic health record.
The next question is, do you find that changing EHRs impacts the patient in any negative or positive ways?
You mean changing from paper to electronic? It kind of, there are definitely things that physicians need to pay attention to when they're switching over, because there's definitely a little less potential, less literal face-to-face time. And if you're doing your note creation, clicking, typing, during the actual encounter, you have to sort of train yourself to still pay attention to the patient, still listen, still interact with the patient while you're capturing notes electronically, whereas before maybe you just scribbled on a piece of paper and maybe dictated later afterwards or whatever. So you do have to sort of pay attention, because it is easier to collect a lot of this information during the actual visit rather than afterwards. Some of my partners do scribble their information. They still see patients the way that they used to, and then they take their scribble into their office and create the electronic note. But that tends to be a slower process than trying to do it on the fly. But you do have to train yourself so that the patient still feels like you're participating in the visit and not taking care of the computer. So it's a risk, but most physicians can make the transition. I think I'll tell you, many of my patients love the fact that we're on electronic records. They perceive it as being better quality. They know that the information that they've provided is accurately captured, and they can see on the information that we give them at the time that they leave the office that we've captured exactly what they were complaining of, and they have a written piece of paper that describes what the treatment is going to be, and their prescriptions are sent electronically. They do love that aspect of EHR.
Thank you. That was the last question.
Well, I just want to say, AGA staff, if you'll feel free to post my email so that if people want those forms, I'd be happy to send those along to anybody who wants those forms.
Thank you.
Okay. I'd like to thank everyone for joining us today for this AGA webinar on choosing an electronic health record. Please continue to read AGA eDigest for more information about electronic health records and government regulations that will continue to affect us all. And if you want to listen to this archived presentation, you can visit the website at www.gastro.org. Thank you all for your participation.